This presentation is going to be on the mechanisms of hormonal function. There are 5 functions of the endocrine system. Number 1, differentiation of the reproductive system and the CNS in fetus. Number 2, stimulation of growth and development. 3, coordination of the male and female reproduction. 4, maintenance of optimal internal environment. And 5, adaptation to emergency demands of the body. And this presentation is going to demonstrate those 5 functions and the hormones that are associated to those functions. We have control and communication due to the integration of the nervous system through the autocrine, paracrine, and endocrine hormones. There's 3 basic secretion patterns. We have a diurnal circadian pattern regulated by cortisol. We have patterns that depend on the levels of the circulating substances like calcium, sodium, potassium, thyroxine, and the hormones themselves. And we also have a pulsatile or a cyclic secretion pattern demonstrated by growth hormones and the menstrual cycle hormones. These hormones operate within a feedback system, and they affect only the target cells with the appropriate receptors. They're very selective. Steroid hormones excreted by kidneys or deactivated by the liver needs to be considered as well. Hormones are released in response to the alteration in the cellular environment. They are heavily regulated and they are in control and they know what is expected of them. To maintain a regulated level of certain substances or other hormones, they need to be able to react to the environment in which they're in. There are chemical factors involved, such as blood glucose or calcium levels. There's endocrine factors involved, like a hormone from one endocrine gland which controls another endocrine gland, and so there may be a cascade of hormonal release. Think about the pituitary hormones or the reproductive hormones. And lastly, we have the neural control with the sympathetic nervous system, direct stimulation of the kidneys, and the release of epinephrine from the adrenal medulla are examples of these. We also need to understand what is a feedback loop, and the negative feedback loop is the most common in hormonal regulation. So the amount of a hormone or its effect is going to be regulated in response to the gland. Like a thermostat, your hormone or the chemical levels are going to be returned to a set point. So whenever it's too high, then your body tries to regulate and make it come down. If the set point is too low, your body is going to try to regulate and bring it back up to that set point. So for instance, with the situation of having low T4 or T3, which are thyroid hormones, then this is going to trigger TRH in the hypothalamus. TSH is going to be released then in response by the anterior pituitary cells, which will increase the levels of T4 and T3 by the thyroid. So it understood that this decrease in T4 and T3 needed a response, and that response was to move TSH out of the anterior pituitary cells and increase the T4 and T3 by the thyroid. That's one example of a negative feedback loop. Going back to the abbreviations, TRH, this is thyroid tropin releasing hormone, and TSH is thyroid stimulating hormone. These are other examples of feedback loops. You can see here that the central nervous system gets some type of positive or negative decrease or increased input. The hypothalamus will then respond by releasing hormones and factors that will help to increase or decrease in response, or it will release inhibiting hormones and factors that would increase or decrease in response. This will trigger the anterior pituitary the tropic hormones, which will have a short feedback loop on the anterior pituitary, triggering the hormones through the target organ to elicit a physiologic effect. You can see here in this picture what we talked about on the last slide, where T4 and T3 may be too low, so then therefore TRH is then triggered to trigger thyroid stimulating hormone to release more T3 and T4 as a negative feedback loop example. But now we have to look at the positive feedback. Hormone stimulates continually through the secretion until appropriate levels are reached. Increasing the estrogen levels is going to exert a positive feedback on the anterior pituitary secretion of LH, which is luteinizing hormone. The pre-ovulatory surge in luteinizing hormone will trigger your body into ovulation. Now we're going to talk about hormone transport. Protein hormones like insulin or antidiuretic hormone, which is ADH, are water soluble and free, meaning they're unbound. They have short half-lives and they're catabolized by circulating enzymes. They bind to cell surface receptors easily, but they're uneasily diffused through the plasma membrane. Our lipid-soluble hormones, in contrast, like cortisol or T4 and T3, are transported, but they're bound to water-soluble carrier or transport proteins. Because of this, they have longer half-lives. They bind to cytosolic or nuclear receptors, and they're easily able to diffuse through the plasma membrane. And there is an important balance between our free or unbound and our bound hormones. Okay, so remembering again, the free are water soluble and the bound hormones are the lipid solubles because they need a carrier transport protein. Half-life. This terminology describes the time that it takes to decrease the concentration of the hormone in your body by half. And then it's positively correlated with the percent of protein binding as well. So thyroxine is 99% protein bound. It has a half-life of 6 days. But aldosterone is 15% bound. So its half-life is shorter, only 25 minutes. So the more bound they are, or the potential of their binding to protein, the percentage, the higher the half-life is going to be. We also have specific hormone receptors that are located in the plasma membrane or in the intracellular compartment of the cell. Fat-soluble hormones connect to intracellular receptors for fat-soluble hormones. The same thing with water-soluble hormones or peptides. They have their own specific hormone receptor as well that would fit these water-soluble hormones. So they need to fit one another. So what is the mechanism of hormone action? This is the sensitivity of the target cell to a particular hormone related to the number of receptors per the cell. So the more receptors, there's a higher affinity, meaning that there's more sensitivity to that specific cell. With low concentrations of hormones, this is going to increase the number of receptors per cell. So we have this upregulation. But in reverse, with high concentrations of hormone, we're going to have a decreased number of receptors because there's so much, right? So we're going to have down regulation. An example of that would be insulin receptors. That's an example of down regulation. These concentrations can change quickly and they can change rapidly within hours, and that affinity for the receptor to bind to a specific hormone is going to be affected by the pH. So for instance, in a patient with diabetic ketoacidosis, meaning that their sugar is really high, the decrease in pH will decrease insulin binding capacity as well. And you can see this example of upregulation and then the example of down regulation. So in upregulation, you have a lot of receptors that are available, and then in downregulation, you don't have enough receptors available. So low concentrations of hormones increase the number of receptors per cell, that's upregulation, and high concentrations of hormones decrease the number of receptors, which is downregulation. Hormones have either a direct or permissive effect. Direct effects are like when insulin helps move cells into the cell. Permissive effects are like when insulin helps mammary cells to respond to prolactin. So it's more of a helper. It doesn't have that direct influence. The hypothalamic pituitary axis regulation is a regulatory system that you will need to understand in order to talk about the alterations of endocrine system. The hypothalamus is considered the control center, and you can see that with decreased hypothalamic function, you're going to have a decrease in all of these hormones, which will affect the anterior pituitary to work on these hormones as well. So the hypothalamic pituitary axis will form the structural and functional basis for the central integration of the neurologic system of the endocrine system. That hypothalamus is the bridge that will signal multiple systems to the pituitary gland, which we consider to be the master gland. The pituitary is consistent of both the anterior and the posterior pituitary. This is going to keep the hormone levels in a very narrow range. It's going to help to regulate. So for instance, the thyroid, the adrenal cortex, the gonads, they all have a negative feedback loop that involves the hypothalamus pituitary system. We also need to know the adrenocorticotropic hormone, which is cortisol, ACTH. And we need to understand with the melanocyte stimulating hormones, MSH, this is producing melanin, which provides our pigmentation. Another hormone in the anterior pituitary is the somatotropic hormones of hypersecretion of growth hormone, which causes acromegaly or giantism, and prolactin, which would stimulate amenorrhea, galactorrhea, and erectile dysfunction. Lastly, we have glycoprotein hormones like the luteinizing, follicle stimulating, and thyroid stimulating hormones. The anterior lobe is the glandular organ that makes all of these hormones. The posterior pituitary hormones is a neural organ. That posterior lobe is a neural organ, and it stores and releases two hormones that the hypothalamus makes. It's going to synthesize with the binding proteins to stimulate antidiuretic hormone, which controls our plasma osmolality. It also decreases circulating volume. So think about antidiuretic hormone. Its name, antidiuretic. It's trying to decrease diuresis. We have antidiuretic hormone that helps all of us at night from getting up to use the restroom all night long, right? Unless we have an underlying like urological condition. With enough antidiuretic hormone, it is going to concentrate our urine during the nighttime so that we don't wake up and have to void, but we can still excrete the same amount of waste. It also will release oxytocin. Okay, posterior pituitary will also release oxytocin, which involves your uterine contractions, the ejection of milk in a mother who is lactating, and also involves and regulates sperm motility. So the next week or so, we will be talking about endocrine disorders. So the etiology of these endocrine disorders are either going to be congenital, infectious, autoimmune, neoplastic, idiopathic, or iatrogenic. So let's go over what that means. Congenital disorders are anything that has to do with an inborn error of metabolism. Congenital adrenal hyperplasia is an example. Infectious has to do with the viral or bacterial infections. Adrenal crisis is commonly associated with an infection or injury. An autoimmune disease like Graves' disease or Addison's, these involve genetic predispositions and environmental triggers that result in the dysfunctional secretion of that endocrine gland. We also have neoplastic issues that have to do with hormones producing hormones that are produced by abnormal tissues. So if there is a malignancy of the organ or gland, that is supposed to produce that hormone, we may have a neoplastic etiology of endocrine disorder. So think about small cell lung carcinoma. This has to do with ADH, and it can cause SIADH, which we will be talking about in the next presentation. It is a endocrine disorder or alteration. If we talk about something that's idiopathic, this means that the target tissue fails to respond to a hormone. And iatrogenic means that it's induced by medical treatment. So something that we've done medically, like chemotherapy or radiation, that's caused the endocrine disorder. Take some time to look at this slide. I really do think that this slide is effective visually because you can see here, for instance, the adrenal cortex has to do with ACTH, thyroid, TSH, our testes, FSH, and luteinizing hormone. Same thing here with a follicular development of estrogen secretion with the ovaries. You can see that prolactin is tied to the mammary glands. Growth hormones have to do with adipose tissue, muscle, and bone. Our mammary gland is also tied to oxytocin, which is tied to uterine contraction. ADH has to do with kidney and water absorption. This is something that you want to try to understand and memorize for the upcoming week. What about aging in the endocrine system? Are the changes in the endocrine system consequences or are they the cause? Well, for the thyroid gland, we're going to have glandular atrophy that occurs as we get older, fibrosis, nodularity, increased inflammatory infiltrates, and a decrease in TSH naturally as we age. Our pancreas, we may have impaired glucose tolerance, higher incidence of diabetes. Our pancreatic cells are replaced with fat. We may have decreased insulin secretion of the beta cells and insulin receptors, and just overall increased insulin resistance. And for the parathyroid gland, these are related to alterations that happen with our calcium balance, like inadequate intake of calcium, malabsorption of calcium, or renal changes of calcium that occur as we age. But also there's some disease processes that can potentiate these things or make them worse as well. Growth hormone and insulin-like growth hormones. So both will decline as we get older, and this is called the somatopause. And they're linked to decreases in our muscle size and our function, the fat and the bone mass of our older patients you might have noticed, and the changes in reproductive and cognitive functions of our patient. In terms of our adrenal gland, the clearance of cortisol is decreased. It takes a longer time for cortisol to be excreted through. The plasma levels of adrenal androgens will gradually decrease, but dramatically during advanced age. We're going to see a more influential decrease, and this is called adrenopause. And then in terms of antidiuretic hormone, we might have hyponatremia, so low sodium, and SIADH is very common as we get older as well.